Hi, everyone. Before we get into this episode, we want to briefly talk about what's going on right now in our country, specifically systematic racism and oppression that has occurred for hundreds of years. Some might ask, why is a public health podcast talking about this? Why can't we stay in our lane and just keep talking about COVID-19 and health delivery? Well, this is our lane. We've spoken a lot about social determinants of health, which is a huge portion in public health. To provide a refresher, social determinants of health is defined as conditions in the places where people live, learn, work, and play that affect a wide range of health risks and outcomes. Hence, racism is a social determinant of health. Systematic racism, as a cause of numerous health problems, should and will be the primary subject of their own episode. However, just to take a few recent examples, health outcomes for those with COVID-19 are reported to be far worse for Black Americans. Back in April, CDC revealed that 30% of COVID-19 patients are African Americans, even if they only make up 13% of the population. Mass incarceration destroys family units and lessens people's abilities to obtain a job, potentially locking them out of income, insurance, and perpetuating the racial wealth and opportunity gap. So as people in public health, we cannot ignore this. We cannot do public health without listening to members of our community when they are hurting. And we will keep talking on here and fighting inequities because we will never achieve any of our health goals without addressing the big elephant in the room, racism. In future weeks, we will have episodes specifically addressing the damages that these attitudes have towards mental health, mental, physical, and community health from the perspective of people who have lived this experience. All right, so here's this episode. Welcome back to From the Front Row, brought to you by the University of Iowa College of Public Health. I'm Oge Chivo.
And I'm Ian Bukta. If this is your first time with us, welcome. We're a student-run podcast that tackles issues in public health. Hey, Oge, what are we talking about today?
Well, we're talking about health equity for refugees with the United Nations Relief and Works Agency for Palestinian Refugees in the Near East. People are being displaced around the globe more and more because of unrest, economic opportunities, and war, which will only intensify as the global population grows and climate change continues. So, to understand how to best care for displaced people, we sat down with a member of an organization that has been doing it for years. According to their website, they provide protection and assistance to around 5.6 million people and is an agency of the United Nations. They also provide healthcare to refugees who need it.
And healthcare is what brings our guest, Dr. Akihiro Seita, to this podcast. Dr. Seita is the director of the health department at UNRWA, as people call it, and is an advocate for mental health issues and a leader in health reform around the world. Steve Sonia and I sat down to talk to Dr. Seita to talk about UNRWA, what they do, and Dr. Seita's own experiences in public health. Though I do want to note two quick things before we jump into this interview. We recorded this interview back in February, and that's before, of course, COVID had fully emerged. So I just want to note that when we are talking about COVID, or if you notice that he's not really mentioning it as a major issue, and for the fact that we're actually in the same room as him, all of those things would have been affected by COVID. Of course, they would all have been changed, but we did record this in February before COVID had really emerged as a major issue in the minds of policymakers and had shut down countries. The second note I want to make is that we did have a bit of microphone trouble. So if the audio is a bit rocky, I'm so sorry about that. But you should still listen to this interview because one, Dr. Seita's microphone was just fine and he does most of the talking. And he had some great stories and some great information. All right, here is our interview.
Dr. Seita, welcome to our show. Can you kind of state your position and give us some background into how you ended up where you are now?
Okay, so my name is Akihiro Seita. I'm the Director of Health for the United Nations Relief and Works Agency for Palestinian Refugees. So it's a pretty long name, UNRWA, and we often call it UNRWA. So allow me to say it UNRWA. Yep. And then I'm the head of the health of UNRWA. UNRWA was established in 1949 After 1948, when the state of Israel established and the people who used to live in the historical Palestine left because of this conflict at the time of the independence by the Israel. And then the United Nations established UNRWA 1949 to provide the care for those Palestinian refugees who fled from the historical Palestine to the neighboring places like Gaza, West Bank, Jordan, Lebanon, and Syria. And then the UNRWA started operating to support to these people from 1950. And then now that after 3 years, that they're still in the refugee state food, and the UNRWA continue to provide services. And the two major services, one is education. It's a school of 700 schools of 500,000 students. It's quite big because that the Palestinian refugees they are the descendant from the original refugees. And then now it's 5.6 million people registered for UNRWA as Palestinian refugees, which is, I understood that almost double of the people of Iowa, correct?
Yeah.
So it's quite big. So the 700 schools, 500,000 students. And for the health-wise, we provide the primary health care only, clinics only, no hospitals. And 140 plus clinics with the 3,500 staff. And we have around 3 million people coming every year with almost 9 to 10 visits, because some people that comes twice or 3 times. So that's what I'm going to do. So my job is to make sure that these primary health care will be provided in high quality and high efficiency to the people we serve, which is Palestinian refugees.
With that side of things, with the quality and everything like that, is that an issue? Because I know in the state sides, sometimes we focus a lot on quality, on access, and on cost. How are you focused on the quality assurance when you're talking about these types of people?
Sure, because primary health care is the front line of any health services, so the quality is most important. And what we did for quality improvement is that if I ask you what is the main cause of death among Palestinian refugees, and many people answer this is infectious diseases, pneumonia, diarrhea, or the pregnancy-related ones, either the pregnancy or delivery. The answer is no. The main cause of death on the refugees, Palestinian refugees, is non-communicable diseases.
Really?
Yeah, diabetes, high blood pressure, cardiovascular, cancer, and the tobacco-related lung disease. And this accounts probably 70 to 80% of cause of death. And this is a very unique feature of the refugee health at large in the 21st century. If you see the last century, that the refugee health is primarily infectious diseases and pregnancy babies, but it's not anymore. And the one big reason is that where the refugee comes from now, Palestine, Syria, Iraq, these are middle-income countries. It is a middle-income country. In the middle-income countries, that the infectious diseases are well controlled to a large extent, while that the non-communicable disease expanded. And the one big reason for the non-communicable disease high is that the poverty. And I'm sure it's the same in the United States. The more poverty, the higher the non-communicable disease. Is that correct? Yeah?
Right, exactly. Right.
And exactly the same reason that the access to the healthy lifestyle is limited, access to the healthy food, access to exercise is limited, so because they become non-communicable disease. So to address this is our main problem. So to address the non-communicable diseases, what we did is two major things. One is that the introduction of the family medicine approach, which is to say that we put say if we have a health center with 3 doctors, we divided the population by 3. It's like a UK system, United Kingdom system. So whenever the person goes to a health center, they see the same doctor, coupled with the nurse and midwife. We call it family health team. So that's the one part. The second part is that because non-communicable is very predominant, that we introduce electronic medical records, e-health. And because it will allow us to make the continuity of care, but also the continuous monitoring. Because diabetes, high blood pressure is lifelong. So the paper-based record is impossible to measure the outcome. Say like outcome-wise that how regular they are coming, compliance, and how many of them are controlled. Say diabetes, how many of them are under hemoglobin A1C, or high blood pressure under 140/90. That kind of things is not possible to do in the paper-based one. So this we did too. And to do so that we start training our doctors for the family medicine. So by doing this, we try to improve the quality of the services with a special focus on non-communicable diseases.
Is there a worry with that when you're talking about mobile health service, right, and monitoring? I don't know what the technological infrastructure is like for here, it's definitely a problem for a lot of people. A lot of people have reliable access to internet. Expanding those services can be tremendously difficult. How are you able to overcome that in this situation?
Okay, so historically, as I said, we have 5 fields of operations. Gaza, West Bank, these are both in Palestine, Jordan, Lebanon, and Syria. And in each places we have 20 to 30 health clinics. It's a stable stationed health clinic. So that this is a health center is open in the area where there are lots of refugees are there. And then we still have more than 60 refugee camps. And so within the camps that we have health clinics. But the camps is not in tents and something like this. It's after 70 years. So it's a semi-urban setting.
Okay.
And then so we have a health center. So access is ensure that in principle that by putting health centers there. And in some places like West Bank and then Syria, and to some extent Lebanon. But Syria and the West Bank, because access is sometimes compromised. In West Bank, because of this occupation, because of the checkpoint, that people may not be able to move freely whenever needed. So we established a health point where it opens, say, it's like this. One team of doctor, nurse, and the pharmacist move to the 3 health points in a week. So this health point opens 2 days a week, 2 days a week, 2 days a week, and 1 day, something like this. And in case of Syria, that they really go. Because of this access issue, the conflict and war. And then so some area in the southern part of Damascus, they go once a week. And if the security situation improves once a week, if better twice a week, it depends on the situation. It's like they go as a convoy with sometimes we have a mobile dental microbus with a dental seat, go there once a week, twice a week, so they go there. So try to address the access as much as possible, but it's compromised because of security. Yeah.
So going back to UNRWA as a whole, what is the kind of key focus and goals, now that we're in 2020, what are we headed towards the organization?
So as I said that we introduced family medicine and the electronic medical records to address non-communicable diseases. That will continue the main issue. The other focus we are now doing is mental health. And I don't think I need to explain to you why mental health is a problem, right? Yeah. It is a problem. And then we introduced that the WHO established a mental health global action plan, abbreviation of which is MHGAP. And then that we train almost all the health center staff for the MHGAP to introduce this. This is not to say that all the mental health issues, but limited ones. Primarily the psychosocial support whenever they come. And if they truly need clinical care for the mental health, we do the depression and then that stress. And our doctors will prescribe antidepressant, fluoxetine or Prozac. And to do it. So these are the ways to do it. So for the Palestinian refugees, health in the 21st century is NCD. So that's our main focus, to how to address NCD. And with the help of the electronic medical records and then continuous education. And then now that the NCD will include the mental health. Huh?
And what's something about refugee health that you think everyone should know?
I think first thing I really would like people to know is, as I said, the disease pattern changed in the 21st century, particularly in the Middle East. And then that it is not the diarrhea. And of course, infectious disease is important. There's no question about this. But if you really see of the refugee health, it's NCD, diabetes. So that diabetes, we have a type 1 and type 2, and type 1 is wholly dependent on insulin injection, right? Then you can imagine that if you are the 16 years old boy, type 1 diabetes, and the crossing border from Syria to a neighboring country because to save his or her family's life, then if there's no insulin, what is the real problem? I think when I ask the expert, sorry, I could be wrong, but when I ask the expert that if you lack of insulin for 2 weeks, the guy will develop ketoacidosis, and then life threat. So that's kind of it's actually the people think that diabetes is a chronic one, so nobody dies quickly, and that is not entirely wrong. But in the case I said is that it's an acute life-threatening condition. So same for the cardiovascular high blood pressure. And of course that in the refugee is most vulnerable, so the stress is high. And so I think that is also the important thing. So what I want people to know first is that the NCD is a problem. And the second is that the care the NCD is not always easy, challenging. And our refugees are more stable, 72 years, but the Syrian refugees or Iraqi refugees, they move around. Then how to make sure the continuity of the care for the NCD is the most important part.
It's interesting that you make the point that things like diabetes that we consider to be chronic here in the United States are not chronic diseases, because if we aren't treating them, then they aren't chronic. They become acute, and it can kill people. That's a really good point.
Yeah, I think if we see the United States, I'm not the expert of the U.S. obviously, but if the immigrants, whatever the legal status, they're crossing from the south to the U.S., and some of them young, right? As far as I see the news, and then there could be the diabetes person there. And how to make sure that I think is a problem. And in this state of Iowa, if you check the immigrants from Mexico and the southern part of Latin America, I could be totally wrong, but I won't be surprised if I'm correct that NCD or chronic condition is a problem among them.
So someone I know very well, actually with these populations, and her work is basically, when you're delivering healthcare. How do you track down people who have to effectively, live off the grid to not be found because they're trying to work, and of course they're trying to be deported at the same time by the government. And so how do you get medication into their hands?
So in this regard, that if I extend that one big challenge to the world for refugee health is that NCD medication, chronic condition medication, are very expensive. It's really expensive. And then that for insulin, we got a very good price internationally. It's $2.3 per vial. We don't use analog. We use a human, but it's okay. But I think it's extraordinarily expensive, the NCD medicines, the high blood pressure medicines. And then that, that the hemoglobin A1C test. For us, it's $3, $3.5 per test. So let me share one example. I used to work for tuberculosis before joining to UNRWA. And then when I started tuberculosis, like your age, one course of treatment of the 6 medicines, 6 months, was more than $100. One course, in any part of the world, at least $100. And then what the world did is, one is standardized treatment, for the globally standardized this, and then they went to they developed the global fund to fight AIDS, TB, malaria. They did a global pool procurement based on the standardized treatment. So they have only 2 treatments, first time and second time. And then you can easily quantify, right? How many first time ones, how many second time. And then you can buy a bulk. So after this establishment of the global fund, one cost went down less than $20. And now less than $15. And I think in the era of NCD, if we can standardize treatment, that is not impossible. And then that is a great help, because insulin is, there's only 3 major companies producing insulin in the world. It's a monopoly. But I don't think that technically, I think technically we should be able to have a generic insulin. If so.
Yeah, and people die in the United States. There's actually it's not common, but there is a phenomenon of people right as they hit 26, or the first time they're on basically between their parents' insurance or going from one insurance to another, and not being able to afford insulin, where people have died in the United States because they've been trying to ration insulin to get through.
I think because the most important thing I learned in UNRWA's work is 2 things. One is that, example mental health, that the person can become healthy only when the society they live in is healthy. I think that's what I learned most. And then that it's not because of lack of access to the services, lack of access to quality of the services, they become sick. Of course they do, but the most important, the health society itself is not healthy. Like high employment and of course war and the others, it's not healthy. The second thing is the refugees. Even in the Middle East, where I work, refugees are the most vulnerable people. Most weakest segment of the society. And what I learned is that all the problem of that society has will accumulate, concentrate to that weakest one. So if I see the refugees, I could see that what are the problems like Jordan has, what the problem Lebanon has. I can see all the problems in the one. Of course, we cannot generalize this because society is so different. I think that's an interesting part of refugee health, that not only providing the health, but it reflects the society at large where they are.
used to work with folks who had HIV and other injection drug use populations. It was something I did a really long time ago. And I think you really hit talking about, it is a reflection of where are we putting our focus in, what are we doing to help those people who are on the stigmatized end of things. And then you're right, it's not just about access or throwing money at the problem, but I think it is a curative community ideology about how are we going to treat people, what are we going to value as a society.
I agree, yeah.
And then, I want to also bring it back to the tuberculosis point that you made earlier, talking about the prices. Again, I used to work as a case manager for maritime ships. And so we had cases of people who would get tuberculosis and they would be brought to the United States. And I remember, seeing the final bill, and it was astronomical, even flying someone back home on an air ambulance because they had
infectious.
Exactly. It was about, I think, $300,000 minimum for that kind of thing. And so just hearing that price change between those two entities, I mean, it really shows you where should we be putting our emphasis, especially with tuberculosis as an infectious disease. With your population that you're working with, is there an area that you are most focused on? Is there an area that you feel most personally attached to that you'd like to see fixed?
I think the answer is Gaza and Syria and then Lebanon, these three places. The reason is that, say, like in Jordan and the West Bank, in Jordan, many of them have a historical reason they have a Jordan citizenship. So that they have access to Jordan National Health Services, which is getting better. And the West Bank, they have access to the Palestine Health Services, and which is getting better. And Gaza, although it is part of the Palestine, but the government service is not getting better. So that's we really need to have. So in Gaza and Lebanon and Syria, we are quite often the last resort. If we don't do this, they have no access. So these are the areas that we focus on this. So say in Syria, obviously, that in the past in Syria, government of Syria treated Palestine refugees very well. They gave all the same rights except for the voting and the military services. Other than that, they can go to any health service of Syrians, like Syrians. But now that it is limited, so that we become a last resort. Say, for example, in Gaza, back to Gaza, I can tell you how it looks like. In Gaza, we have 1.3 million Palestinian refugees. And over 1.3 million, 1 million are relying on our food assistance. And so which means, and at the beginning, I said 10 years ago, it was less than 100,000. Now it's increased to 1 million. So that's how important UNRWA is. In Syria, I think more than 90% of our refugees receive our cash assistance. Because there's no economy, it's very difficult conditions. So I think these are the areas where we are needed, we focus on this. Yeah?
And then right now, what are you kind of focused on with those strategies to manage this refugee crisis that's going on? What are some of the key areas that you are working on?
Yeah, as you may know that we are in a financial crisis. So UNRWA was established in 1950, started operating in 1950, and our mandate was 3 years.
There you go.
So at that time, that the world thought that it should be gone in 3 years' time, and then nothing happened. And I don't know how many 3 years happened. And then it was extended last December, and there's a United Nations vote, and it was approved. And so from next June, it will be another 3 years. So that is the one. So because of this nature of this one, first thing is that UNHCR is different from us. UNHCR was established a couple of months, if not 1 month after us, and that's specifically only for refugees, but other than that, Palestinian refugees, because Palestinian refugees are in UNRWA. And then so we have two refugee stream, and then it goes like this. And then because of this nature that we have to always raise funds, because it's a temporary organization, still 3 years. So in the United Nations, there's a regular budget which is based on the country's member states' contribution, pulled at the headquarters in New York, and they distribute to the different UN agencies. It's a regular budget, we call it, assessed contribution, which is, say, suppose if we have $100 million, you receive $100 million every year. And that's many UN agencies like this, but not us. Because of temporary nature, we have to raise our funds. And so our annual budget is around $1.1 to $1.2 billion. And then the running for the 700 schools, 140 health centers, and some others are around $800 million. So remaining difference of $300 to $400 million like project, housing, and the infrastructure, one-time investment, and the food support like this. And then the United States has been the strongest supporter in the past, and they always give us around $300 to $400 million, say $360 million. But because of the change of their policy to the Palestine, they stopped 2018. So we have a $360 million minus. And this situation still continues. Although 2018, many countries, including 40 countries, increased their contribution to UNRWA, because it's very simple that, for the stability of the region, UNRWA is important. Just imagine that the 700, so 500,000 students lost the schools and go to the street. It's a national security issue because they could be radicalized. Because if youngsters are frustrated, they could be easily radicalized. And we have around 250,000 diabetes, hypertension patients if they have no access to it is also a national security issue. And so the many countries gave the money, 2018 and 19, but this year it's also very tough because of this largest donor support of the U.S. is now it's not happening, so financial crisis there. So as I said, the running cost is around $800 million. And then our financial forecast says that we may not be able to get the $800 million. And then so our current budgeting is 10% minus. So it's a $720 million. So that's very tough, how we can cut 10% from the needs without affecting the services. And so that in the education, that what they're going to do is that they increase the school class size. If you increase the class size, you need to have less teachers, right? Yeah. Something like that. In the health, that it's not easy to do this, so that we try to minimize any unnecessary expenditures and to make sure we will be able to continue to provide services. And so that we may not be able to replace those retired. We may not be able to replace those who are on leave. So that kind of thing, by doing this, providing service, that's the main part, how we can make sure to continue the services for the Palestinian refugees. Yeah.
Has there ever been, because you're talking about the temporary nature of this program, has there ever been a push, or is there ability to make it a permanent program and say it's going to be like these other UN programs where it's part of it? Yeah.
I think operation-wise it is not a bad idea, but politically then, which means that we never solve the Palestinian refugee issues.
Right.
Because our mandate is, the reasonable nature of our mandate is like this: we will continue to provide the service until the just and the last solution comes to the Palestinian refugee issues. Whatever the international community, country like Palestine, Israel, and the United States agrees, that's okay. Because as far as all the parties agree, it's fine. But until that time, we have to continue. So if we become permanent, which means that there's no way to solve the problem. So that's actually the big problem. Yeah?
And with all of this that you're talking about, the issue of budget cuts is problematic within the United States and for your organization as a whole. What other sources of funding can you come up with besides stuff from the United Nations? Are you talking with other nonprofits or other entities?
Yeah. So at this point of last year, 2019, the main donor was Germany. And then followed by EU, Sweden, UK, and some European countries and Japan. These are the countries they do. Since the amount of money is big, I think we try to always rely on the major donor countries. But the expanded donor base, they say like Malaysia, India, even Afghanistan, they gave us $1 million last year. So expanding this. And private sector is working on this one, including Kenya, Saudi Arabia, and others. But we haven't got Melinda Gates Foundation, Bill Foundation, or that kind of private foundation. We haven't got the money yet. That's what we are working on this. Yeah.
And then looking at this whole situation too, what is kind of this long-term solution that you're working on for refugees? If you were able to have all the funding or do, all the money in the world wasn't an issue kind of thing, what would you be looking to do first and foremost for these folks?
For as far as health services is concerned, make it stabilize. Stabilize means that how many doctors we need and how many medicines we need. Next year, we want to do this year, but because of financial crisis, this is still in the survival mode. But once it gets over that, then make it stable. And our service is stable. 70 years ago, we started this. And if you go to look around the world, which countries exist 70 years ago?
It's a changing world.
Changing world.
Sure.
So that doing this for 70 years itself is fantastic, and quite committed persons. I say that we have 140 health centers. It's 3,500 schools, right? And we have 700 schools with 500,000 students. And as a whole, UNRWA has 32,000 staff, big, and all of them Palestinian refugees. All of them are Palestinian. So that as far as health is concerned, I have never seen such hard-working people in the developing country public sector. I think it's simply because they serve their own people, so they continue to work. Because I'm Palestinian refugees, and my patient Palestinian refugee. We came from the same situation, that we live in the same world, so that they continue to serve. I think with this strength, I think we will be able to continue the service, but make sure that in the changing world, that how to come. And one interesting thing I learned a lot is that we define their salary by ourselves. And the salary is very important. And in the global health or universal health coverage or universal health financing, we quite often don't discuss the salaries. Because the salaries, I don't know in the United States, but in many places it's defined by the Minister of Labor, public servants. It's not even Minister of Health that decide the salary of the doctors or payment of doctors. And then actually that is the biggest part of the expenditure. So education is 95% of salaries. Right? Health, I think for us, 60% salaries, and the 20% for the medicine, 20% hospital payment, because we send some patient to the hospital. And so I think that kind of thing is very important for us. And that, in that sense, it's a very rewarding, interesting job. It's a really interesting job. If you love operations, that's the best job in the world.
That's a really good breakdown of everything, because right now I'm going through what are our biggest budgets. Just like you mentioned, education and medical, they are right neck and neck the most.
And both of them will continue to increase, either we like it or not. And then there's no choice.
It is definitely, foundations of health and foundations of growth for a country, investing in its people.
For health, people living longer, which means more chronic conditions, and the unit price of medicine continue to increase, and the price of expenditure, the investigation or examination increase.
So do you have any last thoughts, anything related to this conversation we're having about refugees before we kind of move on?
Yeah, sure. For firstly, that many people think refugees is something that not their own problem. It's very far. And that is not wrong, because particularly if you live in the big country like the U.S., unless you see them, you don't care. But say like in the U.S., that many immigrants are displaced, and some of them are refugees. And it is, I really would like to say that, it's true that refugees is not our day-to-day problem, but if I see the world that we are by chance not a refugee, I say I was Japanese, I born in Japan by chance. And then that I have no chance, no history of refugee in my family. But who knows tomorrow? I think that's very important for us to remember in changing world. Even the strongest country in the world, in the United States, I think we are always vulnerable to the change. I think that's the important thing to remember. And second thing is that if we see the global health, it's largely driven by the politics nowadays. So people become ill because of politics, and the refugee dies because of bad politics. It's not because of lack of health services. And it's important to see the refugee status, see how the politics moves, to understand the politics. And then I think that's the important area that the global health have to address. Although we are not politicians, so we don't run the politics, but the health diplomacy, so to speak, is very important to make sure that the people in the world remain healthy. I think that's also very important part of refugees. And thirdly, anyway, refugees are not in number. They're individual, and some of them truly fantastic. It's truly fantastic people. There are many good people in refugees who become you have many people who are ex-refugees in the United States, right? So I think it is happening everywhere in the world, and I think it's good to get in touch with them to learn from them. Yeah.
So can you talk about your own history and career progression?
Okay. So when I was young, medical school in the very countryside, I was born in 1961. So, and then when I was a medical student around 2021, boat people? Have you ever heard of boat people? Say like you had a war in Vietnam, right? And after the war in Vietnam, that there's a conflict or sort of confusion in the Southeast Asia. and the civil war between the Vietnam and Cambodia and all the other things. So people left their country as a refugee by using boat because it's on the sea. So went to everywhere, and some of them came to Japan, and all the way up or down. And I felt that who they are, and then that they came with a boat to Japan. So I felt that I want to do something for them in the future. And then that after graduation, that when I graduated, that we have the in those days that there's no good rotation. Then I went to do the rotation on internal medicine, surgery, pediatrics, and then OBGYN. But there's no such system except for the only 2 hospitals in Japan. And one of them is a United States Navy hospital in near Tokyo. It's a 7th Fleet headquarters. And I went there because they have rotations. And then after I finished this one, I was looking for a job. And then that Tuberculosis Institute, I sent a letter to many places. And the Tuberculosis Institute got me. They said, there's a job for you, can you come? And I went to the interview, and then I got the job. And then that institute, I did some clinical work of chest medicine a couple of years. And then after that, there's a Japanese government tuberculosis project in Yemen. And I went there at the age of 30 something, stayed 2-3 years. And after that, I joined WHO and then continued to do this. And 10 years ago, that my boss said, do you want to go my boss told me that you should go to UNRWA as director of health. I said, I have no idea what to do because I'm doing tuberculosis, AIDS, and malaria, and UNRWA, as I said, it does everything, everything primary health care. And but I had a good impression of UNRWA in my previous work because they are hard-working health center. Whenever I went to the health center, they're working hard. So I said, okay. And it's also the bureaucratic-wise promotion. And I said, fine. And then somebody told me you should never say no to promotion. I said, okay. I said, fine, okay. And then went there. Then I'm doing this. So I was not I was interested in refugee at the beginning, but I was not originally doing refugee humanitarian. And then, then came to the refugee work in last 9 years. And I think that working in tuberculosis helped me a lot. Say tuberculosis care is somehow like an established program. It's a global standard how to diagnose, treat, and report and monitor. This experience helped me a lot. And then, say for example, diabetes, hypertension care, it is not globally standardized how to diagnose. It's American Diabetes Association, European Diabetes Association, and they say, for example, use of analog insulin is widely common here, but the WHO is not recommending as a first choice. Human is okay. Use of hemoglobin A1C, it's 4 times a year, but in the WHO says twice is okay. And it's not well standardized. So that kind of things happening. So to put the standardization is very good for the family medicine and the NCD care for me. So I think that helps me a lot. Yeah. And I have a proof for the why TB is good. You know Jim Kim, the World Bank president. He was doing MDR TB because I know him well. And you know Tom Frieden, the previous director of CDC. He was a WHO TB officer in India.
You've got good company with it all.
Yeah. So I think, but the experience, I think, experience of that the TB care help a lot. Yeah.
Well, first, thank you for sharing that background. Really interesting story and like life path.
Yeah.
But how can, just from all of that experience, how can public health be better about promoting our message?
I think one is that, of course, they deliver the results. If you deliver the result, it will become better. Say like if the current coronavirus or COVID-19, if we control well, people say, oh, we are doing a great job. If not, I think. Because in public health, people get attention primarily for the infectious diseases. And the infectious disease is black and white. If you control, win. If you don't control, lose. I think that's deliver the result is one thing. But the second part is that put more human story. I think there's a fantastic story. I think what I learned is that when I was doing tuberculosis, our common message is that we have 2 million people dying every year for TB in the world. And if you translate it into a simplistic way, it is like 2 jumbo jet crash a day. Number-wise.
A lot of people.
Lots of people. But still, then at the end of the day, what I learned is people, it didn't always ring the bell of people. If I say 2 million people die, some people say is it big or small? Because people have no idea how many people die in the world every day or every year or every month. And so that's but then I realized that when I put the human story and then bring the tears or the eyes or the break the heart, because I think only the human heart can break the other human's heart. And so I think that's important for us to raise more human stories, how important it is. And after that, we put the numbers and ask the money. Yeah? And the third thing is that the more global network, global standardization, like the story of the TB, if we can bring $100 treatment cost to $15, it could be done for the other conditions. I think then we should be able to do this. I think that's the three things I learned from the public health, and it's a very important part.
So, what is one thing outside the field of public health that you've been thinking about?
Most important, interesting part is politics, but it's say the question comes: is it outside public health or inside public health? And for me, it is inside public health. At least it's not outside. And I think it's important, as I said, that if you don't think about politics, I think we are not good in public health. Say like you're in the States, I apologize if I'm totally wrong, but health insurance is a political problem in the United States. Right? It's not. It is the public health issue, but it's basically a political problem. How to realize universal health insurance or not in the United States is politics. And I think that kind of things, or how to solve the Palestine refugee issues, health issue, it's politics. I think it's always important to understand for me, interesting in the politics, to read the newspaper and talk to the people and understand how people understand. Yeah.
You've gone through this whole big process, right? You're going through your whole career. What is one thing that you thought you knew, but then later realized that you were wrong about during your journey?
Oh, let me think. It doesn't mean that I did nothing wrong. I did many wrong things. The one thing I did wrong. Okay, let me give you one story. Yep.
Sure.
When I was doing tuberculosis, in the early days, that then once the standardized treatment came in, and then as I said, there are two treatments. One is for the first time, the second is other one is second time treatment. And even in those days that we have a multi-drug resistance tuberculosis, we knew it in a small number. But as a public health, I thought that this is not the priority. Because that if we find 70-80% of existing cases, which are usually drug sensitive, number-wise, and then that remain treating multi-drug resistance later, this is fine. Because it is not entirely technically wrong, because that the multi-drug resistance TB is basically man-made. We don't diagnose correctly, we don't treat correctly, and so that they become, and it's our fault, not the patient's fault. But because of it is very expensive, the medicine is extraordinarily expensive in those days, and it's so complex. Even if we use medicine well, that the cure rate could be 50-60%, may not reach higher. So we gave it, at least I gave it last option. First is new cases, second time, and whenever we establish this. And then that there's one person in the world who told me I'm totally wrong, which was Jim Kim. And then that I think that is a major breakthrough to me. What he said is like this. He said that he was taking care of the MDR TB patient in Peru, if you see his history, and the partner in health in the Harvard, together with Paul Farmer. And then that he is treating the TB patient, MDR TB patient in Peru, and in the conference, he brought them and tell them that I don't care your, say like, I don't care your 1 million patient, I don't care your 2 million patient. I care my patient. Give medicine to them. And then that it's a sort of breaking down what of course ethically we can't say that no, I don't care your patient, right? Right. It's a very good tactics, but also truth in it. We really have to save the patient. So what he did is that he brought all the people in the world and also the other activists in the world to treat them. But also he did fantastically bring all the pharmaceutical companies, the global network, to bring that second line, we call second line medicine for MD or TB down, prices down. So that's what he did, and that's I think the biggest lesson I learned. And it's somehow what Jim Kim and Paul Farmer did was a new public health approach, which you say that say my patient, I don't care your 2 million patient. If I care my patient, that's a success. If not, failure. And then if you're doing the HIV before, right? If you know the history of HIV case, it's very interesting because in the 80s when the antiretroviral came in, 90s, there's a very serious discussion in the United States that it's not ethical to give antiretroviral medicine to Africa because they cannot use it. And then it was not a rare notion in the HIV care world. The only things when it changed is that you know the Global AIDS Conference, the big one, very interesting one. And in early days that the HIV, people living with the HIV occupy the podium with the opening, closing, and just shouting that I don't want to die, give me medicine. And in those days, the antiretroviral, many of them are new coming into the market. So they say, I need this medicine, I don't want, give me medicine. And nobody could say you can die. And also, it's you should not say like this. And then they changed the entire notion. So I think that's, I'm from the very classical public health school, which is if we find a majority of people and cure majority of people, it's good for the community. And then, but that is good, say like modeling of the infectious disease. That will the way to reduce the infection, right? However, that could leave the most vulnerable people out. Say like MDR TB, sorry, but we have no medicine. You cannot do anything. You may suffer, but that is not modern public care. So that's what I learned most. Yeah.
All right, so that's the end of the interview. Thank you again to Dr. Seita for coming on to the pod. In this episode, I really enjoyed the fact that he spoke about chronic conditions. While also highlighting the impact of infectious diseases, but talking about how, well, most people, in as much as we think is infectious diseases that really affect refugee health, there are a lot of underlying chronic conditions that if assessed or if provided with like proper healthcare access in the beginning could all be avoided. But since it's not, and with the assumptions that we hold, people still end up with these adverse health effects and end up dying from chronic health conditions. But Ian, what did you think about it?
One thing I thought that was really interesting is that, you know, as he was talking about things that we would label as chronic here in the United States, you know, diabetes, we can treat that chronically. In places where they have a chronic underfunding of healthcare and a lack of insurance, you know, in communities, you know, even within the United States, but definitely abroad as well, those aren't really chronic conditions anymore. They're non-communicable, but they're not really chronic in the sense that if you don't get treated for a diabetes, it becomes an acute condition in which you can die. And so I think it's really important to think about how historically we've chronically underfunded or underprovided healthcare and what groups have been delivered less healthcare than they should have been delivered. And when we do have these inequities and disparities in who is getting adequate access to healthcare, we see things like what you were talking about at the beginning of this episode. The fact is, you know, if you don't provide healthcare adequately to certain communities, they will die at higher rates from things like COVID-19. And, you know, that is a shame. You know, it's a shame that our country bears, and it is something that we need to make sure that everyone has adequate access to healthcare. I had two other notes. First, we are undergoing climate change, and that is going to be a major driver of refugees. So this interview is really interesting to me because as we think about other people who are going to become refugees over the next 30 years, as climate change intensifies, this is one of the ways that we can deliver healthcare to them. Obviously, UNRWA just works with Palestinian refugees, but at least there's a model for how to set up agencies to help deliver healthcare to people who desperately need it but aren't getting it. And the last thing I want to note is that I just want to note one more time that this interview was recorded before COVID-19. And so, again, our discussions of COVID-19 were speculative, and we didn't have a chance to call him back up before releasing this episode. So unfortunately, we weren't able to tell you about kind of some of the more current news on it, but I think that the interview stands for itself, especially in the long run, because hopefully humanity will get its act together and we'll beat this pandemic.
All right, so we're out of here. You can find us on Facebook at the University of Iowa College of Public Health. We're on iTunes and Spotify as well as the University of Iowa College of Public Health.
Let us know what you thought about this episode and this series at cph-gradambassador@uiowa.edu. That's cph-grandambassador@uiowa.edu.
This episode of From the Front Row was hosted by Oge Chivo, Steve Saunier, and Ian Bukta. It was edited and produced by Ian Bukta.
Thank you to our guest, Dr. Akihiro Seita, for coming on the pod this week. This podcast is brought to you by the University of Iowa College of Public Health.
All right, guys, so that's the end of our podcast. Stay safe, happy social distancing, and say no to systematic racism. See you guys next week. Tiptoe. We're recording for the podcast.